person who finds a solution is a visionary, and a person who goes out and does something about it is a doctor. So now, to share his wisdom, we have Dr. Nishil Shah to speak on an uncommon case presentation on rheumatology. Dr. Nishil Shah is a MD Medicine from GMC Surat. He has done 2 years of fellowship in rheumatology from Ahmedabad. He is practicing as consultant rheumatologist in Surat past 10 years.
Good afternoon. Tell me one thing, what is the most difficult part in the conference? You have to take a lecture after the best orator of this conference. Thank you, Dr. Kunal Shah, for the best lecture of this. Thank you, IMA, for giving the opportunity to talk on the rheumatology. ચાલુ કર.
ચાલુ જ છે.
અહીંયાથી દેખાશે. Okay. For next 15 minutes, I will present the 4 to 5 cases, which includes the solely rheumatological cases, how you differentiated the different conditions from the other causes. As Kunal bhai said, કે 16 વર્ષની ઉંમરે, 35 વર્ષની ઉંમરે, 45 વર્ષની ઉંમરે અને 55 વર્ષની ઉંમરે ઘૂંટણનો દુખાવો એ અલગ અલગ વસ્તુ રહેતી હોય છે. તો મારો પહેલો કેસ બી એ જ રહેશે. A 16-year-old school boy complained of sudden onset of gradually increasing pain and swelling in the right knee joint within 36 hours. 16 વર્ષના છોકરાને 36 કલાકની અંદર સડન કોઈ પણ કારણ વગર જમણા ઘૂંટણમાં દુખાવો ચાલુ થઈ ગયો અને સોજો આવી ગયો. It's a painful conditions. Patient was totally asymptomatic before that. No other joints are involved. Only single joint is involvement. Patient consulted to the primary general practitioner and took some pills but did not get much relief. There is no significant fall or trauma. એટલે કુનાલભાઈનું કામ આમાં બહુ છે નહીં. There is no significant fall or trauma. No history of any connective tissue signs or no history of any comorbidities like diabetes, hypertension or asthma, breathlessness, Raynaud's, skin rash, oral ulcers, hair fall. These are the connective tissue signs. No signs of spondyloarthropathy, that is a psoriasis, IBD and uveitis, and no significant weight loss because it's a history of only 36 hours. After 2 days, patient consulted to the surgeon and some blood investigation was done and x-ray done. કુનાલભાઈએ જે કીધું એ પ્રમાણે કે એક્સરેનું બહુ મહત્વ નથી કારણ કે તમે કરાવો એટલે ઓલમોસ્ટ નોર્મલ જ આવે if there is no significant trauma or fall. This blood report shows some sort of the leukocytosis, that is WBC is around 14,000. Acute phase reactions are increased, that is ESR and CRP, and we expect that X-ray is absolutely normal. To advise is a knee immobilizations and take the NSAIDs. Patient did not get relief within the next 3 days. Of course, 16 years school going boy having a severe pain in the right knee joint and is a bed ridden. Then patient definitely parents get the second opinion and there is an increase in the pain and swelling. Patient took the second opinion. He advised the MRI knee joint and again some blood investigations and patient is advised to get admit. After admission, MRI was done. All the rheumatological workup, that is RF factor is negative, anti-CCP is negative, ASO titer is little high because these are the common reports we advise in all the inflammatory conditions. MRI suggestive of the moderate to large joint effusions with synovitis with grade 2 grunt to meniscus tear. This is the usual findings we find in all the inflammatory conditions. And always there is a writing of the possibility of infective or inflammatory etiology. MRI never suggests that it is a purely inflammatory or it is a purely infective etiology. There is always a dilemma between infective and inflammatory etiology. So surgeon was aspirate the knee joint on the next day. The color is yellow color, cloudy. This fluid shows the leukocytosis, that is WBC count is around 20,000 and all the stains are negative. There is no culture is absolutely normal. Patient is advised for the arthroscopic drainage and synovectomy. Patient followed the advice and patient got operated. This is the real case, and I am not a hypothetical case. And this is all purely, all the cases are purely of my OPD cases. There is no hypothetical case. Patient get operated for the same day and about to discharge on the third day. કે એક બે દિવસ દાખલ થઈ જાઓ, ઓપરેટ થઈ જશે, સારું થઈ જશે, બધું નીકળી જશે. These are the presentation of the patients. Right knee is significantly swollen. Now the patient developed the pain and swelling in the another knee joint, that is on the left knee joint and the left ankle joint, on the fourth day of the operations. Initially for the 5 days, 7 days, patient having a single unilateral joint involvement. Patient is operated for the that because of the possibility of the infective etiology. But now on the fourth or fifth, sixth day, the patient developed another joint involvement. The next day reference given to the rheumatologist. On examination, 3 joints are tender and swollen. On asking the patient history, patient having a high-grade fever with severe sore throat before the 15 days of this pain and swelling in the right knee joint. Routine blood investigation sent HLA-B27, which usually done in the male 16 years old boy patient, and CRP is highly, that is 134. This is a classical case of the reactive arthritis. Treatment is the acute. If the less than 21 days of the history, just give the NSAIDs. As and when required, just give the omnacortil, that is the glucocorticoids, and the patient is absolutely fine within 3 weeks or 4 weeks of the treatment. Maybe patient develop the further episodes after the second episode of the any infective etiology, whether it is upper respiratory tract infection or lower respiratory tract infection or the GI involvement. Chronic, if the patient develop the persistent inflammation in the multiple joints, add the another disease modifying drugs like methotrexate or sulfasalazine, you have to continue the NSAIDs. But the diagnosis is most important because this is the spondyloarthropathy, reactive arthritis. This is also a real case of male patients, father of the dentist, 54-year male patients, having history of the multiple joint pain and swelling in a small and large joint, that is inflammatory type. What is inflammatory type? The patient having early morning stiffness is there, redness, pain and swelling. These are the classical 3 signs are there which we suggest that is an inflammatory joints involvement. Early morning stiffness is around to 60 minutes to 90 minutes. History of generalized weakness, fatigue and low grade fever. Almost all the patients of inflammatory arthritis having a complaint of low grade fever, because inflammation in your body having a multiple joint pain, then patient is complaining કે સાહેબ ઝીણો ઝીણો તાવ જેવો આખો દિવસ લાગ્યા કરે. There is no comorbidities like diabetes, hypertension and breathlessness. No signs of any connective tissue disease, that is petechial rash, Raynaud's rash, hair fall, mucosal ulcers, pedal edema. Past history is significantly nil. On first consultations, vitals are absolutely normal, no rash, lymphadenopathy. Systemic examination, કાકાને જ્યારે હિસ્ટ્રી પૂછતા હતા ત્યારે 4 થી 5 વાર એમને પૂછવું પડે. So some short of the decreased hearing since 1 year. Musculoskeletal examination shows the small and large joints are inflamed, that is tenderness and the swelling is there. Extensor tenosynovitis is there. On investigations, classical inflammatory presentation, that is a hypochromic microcytic anemia, that is HB is around 8.9 to 10. WBC counts is around inflammatory range, that is 10,000 to 14,000, that is 13,000. ESR and CRP is always high, that is the inflammatory acute phase reactants, and RF factor is significantly positive. So we made a diagnosis of, this is the classical case of the rheumatoid arthritis, specifying a small and large joint involvement, and the rheumatoid factor is positive. So treatment is started on methotrexate and the leflunomide along with the NSAIDs, along with plus or minus glucocorticoids. After 3 months of the therapy, patient does not respond well. If the patient having a classical rheumatoid arthritis, patient is 75% well responded with the disease modifying drug, that is methotrexate and leflunomide. If it not responded well within 3 months, think the alternative diagnosis. There is a significant weight loss, fever and anorexia. Now the patient having another complaint of significant tingling and numbness in the left foot joint. Patient કે સાહેબ આખા ડાબા પગમાં ભયંકર ઝંઝણાટી મારે છે અને ઘણીવાર ચપ્પલ નીકળી જાય તો બી ખબર પડતી નથી. Again the blood investigations and imaging studies is done. Chest X-ray shows the some patchy infiltrative lesions and USG shows the multiple lymphadenopathy. Because we usually do a primary screening of this chest X-ray, ultrasounds and the blood reports. HRCT was not done at that time, and empty test was negative because patient having a low-grade fever, anorexia, significantly weight loss, and lymphadenopathy, and the chest X-ray shows the patchy infiltration lesions. They made the diagnosis of the tuberculosis, and the patient started on AKT. After 20 days of the patients, I personally believe if the patient's having a tuberculosis and you start the treatment of anti-tuberculosis drug, patient is well responded within 7 to 15 days. એનો ફીવર જતો રહે, પેઇન જતું રહે, એને ખાવાની એટલે ભૂખ લાગવાની શરૂ થઈ જાય. So patient feeling well-being. But after 20 days of the AKT, patient is not responding. Patient continues same complaint, fever, anorexia, joint pain, lethargy, weakness. So these are the classical symptoms on the 20th or 25th day of the presentations: fever on and off, low grade plus or minus high grade, inflammatory arthritis, tingling numbness in the foot with some weakness also, hearing complaint. જે મેં કીધું કે કાકાને અમારે પૂછવું પડતું હતું કે કાકા કેમ આટલું 3-4 વાર પૂછવું પડે છે. Lymphadenopathy, patchy infiltration in the chest X-ray, ESR, CRP, RF factor is positive, and urine albumin. This is the first time we detected there is acute sediments in the urine. When there is a multi-organ involvement, this is a multi-system disease, always thinks of any connective tissue or rheumatological disease, because multi-system involvement with high inflammatory marker, with any positive reports of the connective tissue, think of multiple differential diagnosis. This is a classical case of the ANCA associated vasculitis. We advise to ANCA by IF and PR3 by ELISA method. Both are strongly positive. So we made a diagnosis of ANCA associated vasculitis, which starts the treatment of the 1 milligram per kg plus endoxan, that is a cyclophosphamide. Patient is well responded and absolutely fine within 15 days of the treatment. All the symptoms are gone within the 4 to 5 days. This is the case 3, 32-year male patients, 4-month history of the mildly painful swelling over the bilateral small joints of the hand, that is wrist and the knee joints. Evaluated by the ortho, always we advise for the inflammatory arthritis. These are the common 3 reports advised by anybody: complete blood count, rheumatoid factor, uric acids, and the ASO titer. So this patient turned out to be a RF positive, treated with the oral steroids, NSAIDs, and methotrexate, because 32-year male with inflammatory arthritis is RF positive, always dumping of this is the case of rheumatoid arthritis, and just started the treatment because we have only 4 reports and 4 drugs, that is methotrexate, lefno, sulfa, and hydroxychloroquine, and 4 reports, that is RF factor, anti-CCP, ANA, and ANCA. But didn't improve with the above treatment. On examination, swelling was predominantly with the mild tenderness. If the patient having a severe inflammatory arthritis or rheumatoid arthritis, patient having a more tenderness than the swelling. This patient having a less tenderness with more swelling on the bilateral wrist, second and third PIP, both of the hands, and the bilateral knee joints. On examination, this is the classical finding of erythematous rash over the multiple body area, which have a decreased pinprick sensations. I can show you the images of these patients. Patient having a decreased sensation over both the elbows, small joints, and the abdomen and the back of the region. These are the knee photographs of the patients. So this is the red erythematous lesions with inflammatory arthritis, asymmetrical pattern with a decreased pinprick sensation. This is the case of leprosy. We did a biopsy and it is proven positive for the lepra bacilli. This is a 4th case, 24-year male patients, 3 months of the history of painful bilateral ankle swelling. Patient having a bilateral ankle swelling and tenderness, plus history of the lower back pain. X-ray shows the sclerotic changes along with the sacroiliac joint. Not a inflammatory changes, it is a sclerotic. It could be on the iliac perspective. Evaluated by the ortho people, HLA-B27 is positive, inflammatory markers are positive, that is ESR is 70, starters NSAIDs, steroids, and methotrexate. Because the usual advice by all the people, methotrexate, connective tissue disease, start methotrexate. It's not like that. Presented to us, we usually did the thorough examinations with the primary investigations. We do the chest X-ray and USG abdomen for almost all of the patients. Tenderness presence over the bilateral ankle joint along with the synovitis. On detailed history, patient having a 10 kg weight loss. No history of the fever. Chest X-ray shows this type of lymphadenopathy. Biopsy of the lymph node shows the necrolytic granuloma and AFB is positive. So this is the classical case of the Ponsett arthritis. This is the tuberculous antigen related arthritis. In that case, methotrexate NSAID is not much useful. You have to start the anti-tuberculous drugs and the patient is well responded with the 1 or 2 months of the therapy. This is the case 4. 62-year female presented with the quadriparesis. MRI of the cervical, because a patient having a quadriparesis is always evaluated by the neuro people, and you do a cervical spine MRI. MRI cervical spine shows the degenerative changes. Clinically considered to have a cervical myelopathy with a spinal shock. Treated by the IV steroids, improved dramatically. Within 2 days, patient is discharged. કે 3 દિવસની અંદર patient is improved and the patient is discharged. Similar attack after the 1 week and MRI shows the same changes. 10 દિવસ પછી patient same admit થાય છે and then the patient again evaluate for the another neurophysicians because another MRI was done. It shows the same changes. Operated for the cervical fixation and surgery and discharged with the cervical collar. After 1 week again admitted with the similar complaint. Patient getting a 4 to 5 continuous episodes of this quadriparesis treated by the neurophysicians. Evaluation shows the persistent low potassium levels. The patient is advised to do a antinuclear antibody by immunofluorescence, that is ANA by IF and ANA blot, which strongly positive, and this is the ROLA positive antibody, and diagnosis is the Sjogren syndrome. This patient having a renal tubular acidosis. If you correct the potassium, if you correct the renal tubular acidosis, along with the treatment for the Sjogren syndrome, that is corticosteroids plus hydroxychloroquine, and as and when required the azathioprine or mycophenolate, the patient is benefited with the treatment. There is no further episodes of this type of quadriparesis in the patients. This is the case 5. 22-year female having history of multiple joint pain. In all our patients having a multiple joint pain. If the patient having a multiple joint involvement, best evaluated by the rheumatologist. Severe inflammatory in nature, morning stiffness is more than 1 hour, cannot do a household activity, having a frontal hair loss. This patient having only 2 complaints, frontal hair loss and the severe inflammatory arthritis. Investigation again shows the microcytic hyperchromic anemia with lower side of the pancytopenia, that is the total count is around 4,000 and platelet count is 1,60,000. Of course, all the acute phase reactants are increased, ESR and CRP, and again RF factor is positive. If the RF factor is positive, don't jump into the diagnosis of the rheumatoid arthritis. Think of the other causes. If you rule out all the causes, then over to the rheumatoid arthritis. Diagnosis was made with the rheumatoid arthritis, starting the methotrexate and NSAIDs. Patient is improved. After 2 months of the severe hair fall, on and off fever since 1 month, severe photosensitivity rash and petechial hemorrhage in the palm and hand. Thought to be it's a methotrexate toxicity. કે ઘણા લોકો કહે છે કે methotrexate લીધા પછી વાળ ઉતરી જાય, લાલ લાલ ચાંદા પડી જાય અને તાવ આવવા લાગે. Patient is not well tolerated methotrexate. These are the side effects of the methotrexate. Stop all the treatments. After 1 month, severe disease flare. In between, patient is taking on and off NSAIDs. કારણ કે methotrexate બંધ કરી દીધી, joint pain is severe and patient is continuously taking the NSAIDs. After 1 month, rheumatopathy was done. Clinical diagnosis, classical, it's a systemic lupus erythematosus, but lab advised, it shows the urine +4. So what is the importance of the early diagnosis? The patient took the NSAIDs for at least 2 to 3 months before the diagnosis and it turned out to be a lupus nephritis. If we bombard the immunosuppressions before this NSAIDs, we can save the kidney of these patients. ANA is +4 homogeneous, creatinine is around 3.2, patient is already developed the acute and chronic kidney disease. Biopsy shows the sclerosing glomeruli, treatment started with the endoxan with the steroids, partially recovered but chronic damage to the kidney. Take home message is, diagnosis of arthritis is tricky. Clinical examination has no further alternatives. Lab markers can be falsely positive. Laboratory and radiology can fool you. કારણ કે અમારા પેશન્ટ્સની અંદર બધા જ રિપોર્ટ ગમે ત્યારે પોઝિટિવ આવી જાય. It is not something like that કે RF factor positive or almost every day 2 to 3 reference I get કે ANA positive છે. But patient having no symptoms. That is benefited to me, but patient having no classical signs of the connective tissue disease. Think out of the box for the chronic disease. ESR and CARP major pickup points for the Rheumatological case, that is a chronic inflammatory case. RF factor anti-CCP for the rheumatoid arthritis. HLA-B27 is for the spondyloarthropathy. Counsel to the patients for the long-term medicines, because these disorders are not curable. We can control and we can give the pain-free life to the patients. Thank you.
Any questions from the audience? Thank you, sir. I would like to call upon Dr. Digant Shastri,
First
sir.
time there is no, in the crowd, there is a delegates having a rheumatological case in the family. Otherwise, those who are asking for the questions having one case of the rheumatology in the family. They are solving the query કે ભાઈ મારી તો આ દવા ચાલે જ છે, હવે શું કરી શકીએ? રોકી શકીએ, બંધ કરી શકીએ? પણ no, it's you have to continue for the long term. Thank you. And most of the delegates having a query in the uric acid, because all the reports of the uric acid having a 7 to 9 range and patient on start in the allopurinol. અને આમાંથી ઘણા લોકો allopurinol ખાતા જ હશે, એટલે બહાર નીકળો એટલે પૂછે કે ભાઈ allopurinol લેવાની કે નહીં લેવાની? If you know the symptoms of the gout, acute inflammatory MTP or the ankle joint inflammation, don't treat the report. 7 તમારી ઉંમરમાં 7.5 પોઝિટિવ આવશે જ, કારણ કે બધા વાળ સફેદવાળા છે, એટલે 5.5 થી 7.5 ઇટ્સ અ કોમન થિંગ. Don't chase the reports. Don't chase the reports. If you have an inflammatory arthritis because of the gout, episodic in nature, then you have to treat with the uric acid lowering agents. Thank you.
I would like to call Dr. Digant Shastri, sir, and Dr. Ketan Jagidar, sir, to felicitate Dr. Nishil Shah, sir.